And we are live. Hello, Vikram Talaulikar. Welcome again to this is our second science wrap, and hopefully we shall be doing these a little bit more regularly as time goes on. We've got a number of studies to run through here, and I don't know why I'm hearing this twice. Sorry.
I can hear you well, Fiona. My end is okay.
I'm hearing myself in my headphones. I don't know why, on a delay, so I'm sorry about that. So we've got a number of studies to run through here. We've got around about 6 of them, and just in case people don't know who you are a reproductive health specialist at UCL. You are also a trustee on the Menopause Research and Education Fund board, and an expert in all of these sorts of things. And our aim is to make sure that we get the latest science interpreted in terms of and how it applies to people. So, without further ado, this is the first one that we've got. After a diagnosis of breast cancer in women with a BRCA pathogenic variant and a risk of death. What did it say and what does it mean?
Okay, so I think we chose this because there was a recent presentation at the meeting, which was mainly the breast cancer and hormone replacement therapy sort of session at the San Antonio Breast Cancer Conference or Symposium, which is why we chose these studies. The one on the left, which is the study which was in May 2025, the one on the right on the screen is the one that the new abstract that was actually presented at the recent conference at the end of last year. And they come from the same group. It's a group which has been studying women with BRCA mutations, those who've had breast cancer in the past, those who don't have any history of breast cancer, and either of these cohorts of patients being followed up on menopause hormone therapy or hormone replacement therapy, as we call it here. So let's look at the first study on the left there, the one that says what happens when you give MHT or HRT after a diagnosis of breast cancer in women with BRCA mutation. What's the risk of death? Do these women have a higher risk of death because we're giving them HRT? So this is looking at HRT after diagnosis. It's a prospective analysis. It's a longitudinal study. So you follow up patients who are taking HRT and you look at the outcomes. It was made sure that none of these patients who we were looking at as the case group had no prior HRT use, so they hadn't had any systemic HRT before, and then they had the diagnosis of breast cancer, and then they were matched. So you matched the people with breast cancer and taking HRT versus those who don't take HRT, and there were about 183 matched pairs. And then I made the notes to say about 53 of those who were taking HRT were taking vaginal estrogen, and about 130 were taking systemic HRT, so all over the body. It was a 6-year follow-up, so that's a good amount of follow-up there. And there were 9 deaths in the HRT group versus 22 in the non-HRT group. So you can see there were less number of deaths in the HRT group during that follow-up period as compared to 22 in the non-HRT. And that's which were attributable to breast cancer, 6 in the HRT group, 16 in the non-HRT group. And the authors concluded that there was no increase in risk of death attributable to breast cancer. And in fact, there was improved quality of life in the group that took the MHT or the HRT. And so this is very reassuring. That's because, you've got these women with the mutation who've had breast cancer. Traditionally, women in this situation would not be given HRT. HRT stands contraindicated because you're worried about recurrence of the cancer or occurrence of more tumors with HRT. But of course, women do have a choice. And in this particular cohort, they had a choice of going on to HRT and no HRT. There was no increased risk of death in the group that took HRT. A few other notes before we go for questions. So the paper on the right, which is the data that was presented at the recent San Antonio Cancer Symposium, again, this was the data that was looking at BRCA carriers, so women with BRCA mutation, but no cancer history. So this time, this is concentrating on not pre-existing breast cancer, but no cancer history. And these are the women who usually had menopause because of risk-reducing salpingo-oophorectomy. So they had been kind of thrown into surgical menopause because they had the ovaries out, and the HRT was one of the solutions as the treatment of menopausal symptoms. And the age range of patients was quite big, 22 up till 76. average age being around 43 and a half. There were 676 matched pairs. So kind of, they were trying to simulate clinical trial situation, one group HRT matched against non-HRT. And again, the follow-up was about 5.5 years. So decent number of years of follow-up. What did the authors find here? So less breast cancer cases in women who used HRT, about 87, and the non-HRT group had about 128 breast cancer cases. And if you look at the type of formulations, the various hormones that were being used for these women, there was no difference in risk in terms of any particular type of HRT per se, but the two highlights were estrogen only had lower risk, estrogen with bezadoxifene, one of the less commonly used HRTs in the world, because it's not available, for example, in the UK, estrogen with bezadoxifene seemed to have a lower risk. But of course, everything comes with pinch of salt. There are limitations of the study. For example, overall, the time follow-up is short, about 5 to 6 years. There's no stratification of these tumors by what receptor status they had. But there were small subgroups. For example, the BRCA2 group was very small. The bezadoxifene group was so small that you can't really generalize the outcomes or the findings until you have large numbers in future. But again, the message here is favorable. These women go through surgical menopause, have lots of symptoms, problems for their bones, for their hearts in future because they have premature or early surgical menopause. I think individualizing is important because they do stand to benefit both for symptoms, quality of life in their bones and heart. And the data from both these papers shows that it doesn't seem to increase the risk of death from breast cancer or risk of having breast cancer by replacing hormones in that situation. So quite positive finding for BRCA patients.
So is that then you're saying it's got limitations and they're small groups, so then it's not enough yet to change practice, because we have a lot of people who would go, well, this may well be proof of what we've been saying, that HRT is no great risk. Too early to say, yep.
Beyond 50, too early to say. Below 50, we already know this, and the clinical practice actually does recommend giving HRT. So if you go to the next slide, this was a paper that was published way before, I think 5 years ago. We did this for the Royal College of Obstetrics Gynecology. Professor Manchanda was leading on this paper at the time. And again, in this paper, which is free to access, we kind of give the evidence why HRT should be recommended or offered to women who have early or premature surgical menopause until the age of natural menopause, which is 50. And giving HRT does not seem to increase the risk. So this is well-known standard practice, but you kind of get more confidence from some of the newer studies that have been published. What we don't know, as you rightly said, is what happens after 50. Do we have enough to change our practice? Probably not at this stage. And so we individualize. If somebody has menopause after 50 and they're looking for HRT, it's not early or premature surgical menopause, then I guess the evidence helps us to make a decision that there doesn't seem to be very increased risk of death or breast cancer. But it comes with a caveat. It's a small number of patients after the age of 50, and every patient will have to make their own balance of benefits and risk.
We live in a world where people like to extrapolate data from one group to another. Can you extrapolate this data from the BRCA group to any other types of people who have cancer with some other type of genetic variation?
No, I wouldn't do that. If you're going to be sticking to good quality research, it has to be specific to that particular mutation. So we stick to BRCA1, BRCA2 here. In fact, even authors recognize that the number of women in the BRCA2 group, mutation group, are small, and one can't generalize those. It's the BRCA1 that seems to have decent number representation here. You cannot extrapolate this to other mutations or types of cancers.
Good to know. All right. Shall we move on to the next one?
Yes. Next slide is, this is a study about, this is your favorite topic now.
It is my favorite.
So this is basically diagnosing UTIs in women. Can we give vaginal estrogen? In that situation, would it help to reduce the number of UTIs or with UTI-like symptoms? And we're going to focus mainly on the use for preventing UTIs. We're not going to go into nitty-gritties of how we diagnose UTI, what type of cultures are best. That's a separate topic on its own, and it will simply mean we drag on. So this study assessed the prevalence of UTIs, symptoms, How many of those women with symptoms had cultures done and actually found cultures positive for urine infection? How many were treated out of that with antibiotics? How many had vaginal estrogen used? And these were all postmenopausal women. What the study found was the antibiotics were overused, and sometimes the UTI hadn't been confirmed. So even without cultures being positive, negative cultures, the antibiotics were the first to-go method of treating these suspected infections. And they found that the vaginal estrogen was underused. They found that often the women who used vaginal estrogen, the UTIs were lesser, and had it been used for the rest of the population, we would have possibly had less number of UTIs. It was a retrospective study, so going back to medical records, but what they chose was about 62,800 postmenopausal women, so very good number, between 55 to 90 years, so you can see the age range is quite good. Between 2019 to 2022, so that's a 3 years worth of data from where they were getting it. And out of all these 62,000, about 15,242 women had symptoms of UTI. This is about 1 out of 4 women. So 1 out of every 4 women had these symptoms. So you can see how common this situation is and how a simple intervention could lead to so much benefit for so many. Anyway, so they looked through medical records and they describe what they look at medical records, and it's quite extensive. What did they find as results? So out of those with symptoms of UTI, so that's about 15,000, only 36% had cultures. Only those were actually investigated with cultures, and 60% of those were found to have positive cultures. What happens next? Now, those with positive culture, about 28% had antibiotics. Those with negative cultures, 26% had antibiotics. So you can see overuse of antibiotics here. Even with negative culture, certainly getting antibiotics. Only 11.3% or 8% used vaginal estrogen, again with significant lower incidence of UTI symptom. It was about 11.8% in the hormone group, the vaginal estrogen group, and 17% in the non-users. So you can see that vaginal estrogen certainly was associated with a lower incidence in whatever number of women it was used. Those not receiving vaginal estrogen had higher rate of culture negative UTI symptoms. So this is an interesting finding. Those who are not getting the vaginal estrogen, they had symptoms suggestive of UTI, not necessarily actually positive for culture. They were negative for culture. Again, suggesting that it's the overall milieu, it's the vaginal flora, the vaginal and the bladder tissues. Because you're not getting estrogen and you may be having genitourinary effects of atrophy, women may feel symptoms of UTI more often without a documented infection. And you could possibly treat these if you are on vaginal estrogen. What were the strengths of the study? It's a large sample size, thousands of women, an extensive look into medical records. What are the limitations? What are the downsides? Of course, you have to depend on records for any retrospective study, and that often makes it weak, because it could be that some women in the control group were using over-the-counter vaginal estrogen, and this may not have been recorded in the notes. Some may have been given vaginal estrogen and recorded, but not used in the notes. Could have overlooked some confounders. Comorbidities are always not controlled for in studies like these. You can't get every one of the variable to be matched between HRT users and non-users. And of course, there's no long-term follow-up. It's just looking at the number of UTI. We don't know what happened to those women over time, whether the vaginal estrogen stayed consistently effective or not effective after a while. So it has its limitations. It's a retrospective study. But I think a couple of points strike, and based on our current clinical experience, we must have a lower threshold for prescribing vaginal estrogen. It's a very simple, effective, no risk or low risk intervention that can help pelvic health, bladder health, muscles, pelvic floor, vaginal mucosa, and all the symptoms. And we should try and make sure that we don't miss this when we're thinking of UTIs. Often the response with UTI is antibiotic, demenose, other forms of UTI prevention techniques. And what often gets missed is the vaginal estrogen. So that should be right on top of agenda for women. That is what we should be working towards. Any comments or questions from you?
No, I was just going to say take home message. Remember vaginal estrogen as you reach for your prescription pad, and maybe try that first, or at least in combination. Then maybe is that if you're thinking I need both. Yeah, it's an interesting one. But the one I'm really loving is our next one, which is this one. This is really interesting. The vaginal use of estradiol is associated with a reduced risk of rectal cancer in postmenopausal women, a Finnish nationwide case control study. This was really interesting. Tell us all about it.
So this caught my eye as well, which is why I posted it. And one of the first comments I got on that, this is cherry picking. So I don't think it's completely cherry picking, but it's a study which is really nice, and I think could be replicated in other countries and other populations. So this is a fantastic study from a Finnish group. It's a nationwide case control study. So you compare cases with controls. And I'm always appreciating Scandinavians for their registries, for their record keeping, for the huge amount of data they churn in such a beautiful way. So what the study identified was they looked at the primary rectal cancer cases, and there were 5 age-matched controls for every case of rectal cancer. So you have a case, and you try to match 5 people with similar characteristics, as many as possible, for every case of rectal cancer. Wide duration, so 1994 until 2019, more than 1 million Finnish postmenopausal women, huge population. And they were making sure they had not used any systemic HRT. So you're really looking at vaginal estrogen only. And they traced the users. So these are the users who had used vaginal estradiol in either a 25 microgram dose or a 10 microgram dose. And this was between, say, 1994 to 2013. After 2013, they couldn't rely on the data because what happened was there was over-the-counter estrogen available, and that wasn't always recorded in the registries. So they've just stuck to the analysis for vaginal estradiol accurately between 94 to 2013. And then how many cancer cases did they look at? They looked at 494 rectal cancer patients, which is about 17%, and 2,826 controls, 20%. They used vaginal estrogen. So out of all the cases of rectal cancer, 494 versus the controls, 2826, about 17% and 20%, they used vaginal estrogen. And they basically looked at users who were diagnosed. When were they diagnosed with rectal cancer out of those who did not use vaginal estrogen versus those who used vaginal estrogen? Now, the first finding they got was that users of vaginal estrogen who had been diagnosed with rectal cancer, it's a smaller proportion, but those who got diagnosed were diagnosed 9 years later than the non-users. So it seemed to delay occurrence of cancer, if at all it was happening. And overall, if you used vaginal estrogen more than equal to about 3 years, it reduced your risk of rectal cancer in that 94 to 2013 cohort of women. So one, it reduced your risk of cancer. Second, if it happened 9 years later. And the protection appeared to persist even up to 5 years after cessation of vaginal estradiol. So it had some long-lasting effect even if you had stopped using vaginal estrogen. So the authors concluded that vaginal estrogen could be associated with a reduced risk of rectal cancer, about 12 to 23% reduction. And we know this already exists with systemic HRT. So these results are not entirely surprising. Many other studies, including the WHI and a few others, have shown that oral HRT or systemic HRT per se can reduce somebody's incidence of colorectal cancer. There's a slight protective effect. Why it happens biologically is not well understood. It's thought to be some sort of receptor mechanism where estrogen may be binding to the rectal mucosa, stimulating beta receptors, which are anti-carcinogenic. And that may be one of the postulated mechanism of action, but we are not sure. But there certainly seems to be an effect where it's colon and rectum protective effect here. So before we finish, what were the strengths and the limitations? So strengths are large numbers, very good Finnish registry, very good data, long follow-up period of almost 25 years. What were the limitations? Of course, limitation is it's all about records, and records always don't tell the whole story. So there could be confounders. For example, there was no matching for diet types. There was no matching for smoking. There was no matching for, I think, BMI. or the lifestyle overall. And so there could be subtle differences in lifestyle which could have influenced these results. And you can never 100% say no. They also couldn't assess estriol or other estrogens because it was mainly about estradiol, 10 and 25 microgram per series. So they couldn't assess other estrogens. Those are the real downsides of all this amount of data. But the interesting thing is we should be now possibly keeping this at the back of our mind in day-to-day clinical practice, is that not only vaginal estrogen has all those benefits which we mentioned, the UTI prevention, the pelvic floor, the vaginal mucosa, the symptoms, the quality of life, but equally, it may be that if this study is replicated in more populations, more observational data, there is some protective effect of local vaginal estrogen, and that would be another tick box in the positives, which far outweigh any risk for vaginal estrogen.
Brilliant. Yeah, it was a really interesting one. So why did they say it was a cherry picking exercise? Because it's quite a large number of people in the end. When you've got 5 sets of paired controls, we're looking at a considerable number of people.
I think because it's a single study and we don't have more replicated results. So maybe the person who criticized the study thought you're just trying to look at one population, one particular study which was focused. And if you run search statistics on different populations, you might find there is not much of a difference. And then you will conclude that, okay, we did this study in 3 other people and we didn't find the same. So you've just picked the one that's available. So that's sort of a thing. And I agree with that, because any research finding has to be replicated in different populations by different groups and scientists. Only then one can say those findings are reliable.
Brilliant. All right. Yes, that makes perfect sense. Now, this next one is also incredibly interesting because we often don't think about other types of cancers that are estrogen or progesterone sensitive. So this is looking at recommendations on the management of meningioma and sex hormone therapy, the results of a collaborative effort between neurosurgical, endocrine, and gynecological societies. So what do we know about this one?
Right. So meningiomas have been a problem with use of hormones for a while. When I say problem, it mainly means we've always known there have been reports being published or information coming that meningioma are basically tumors of the central nervous system, which can respond to hormones. They are not very common. So I was trying to look at the literature behind them, and there are about 6 to 8 cases in 100,000 individuals is the annual incidence. So very, very uncommon. And the incidence peaks in the middle age. Often the median age is thought to be somewhere about 66, but it can start sort of peaking around the middle age patients, and then kind of the 5th or the 6th decade is when you will see most of your patients. Female to male ratio at this age, middle age, is about 2 to 3.5 to 1. So it does seem to have more female predilection. Vast majority are benign. About 1 to 2% are thought to behave malignant. And often what happens is, throughout the paper, the authors say they are responsive to hormones, but if you withdraw the hormones, they tend to regress, or they tend to stop growing from as soon as you've taken the hormone away. Now, why was it thought that meningiomas as brain tumors could, or CNS tumors could, respond to hormone? One, it does appear that their growth accelerates in pregnancy when the hormones are really at the high. Secondly, the presence of receptors. So if you look at various meningiomas, look at the immunohistochemistry, they're positive. Some of them are positive for estrogen receptors, others for progesterone, and there are some for androgen testosterone receptors. The bulk of them, maximum positivity being for progesterone receptors. And then then the authors have done a massive study. They've looked at the literature search to look at all the articles that would be relevant to come up with a consensus statement. What should be done? What do they advise based on the amount of literature out there? And they looked at thousands of papers and then finally just chose the articles that would be most relevant, came up with a number of 237 papers, which is quite a lot of work. So well done to them. Now, let's look at one by one. What did they think when they were trying to look at these papers, and what recommendations did they come up with? So when they looked at oral contraceptives, so these are combined oral contraception, they said that most studies initially said there is no link. So you can kind of have no link with many of the initial studies that looked at use of oral contraception with meningiomas. But there were two retrospective studies, they said, where there was a modest risk increase in the risk of meningioma with use of combined oral contraception. So some studies said no risk, others said there is a modest risk. Why was that? Potentially because they were using different type of COC, different combinations of hormones. They were looking at different populations, perhaps different duration of use of those hormones, and the different ways of categorizing the tumor. So there could have been methodology differences between the studies, but the conflict was there. There wasn't a clear-cut answer as to whether there was increased risk or no. Then the second category is progestins only. So this is progestrogens or progestins, whether it's synthetic progestin or natural progesterone. And again, the authors have looked at all the data to find out which are the ones they would blame the risk of meningioma on. So the most striking ones are the cyproterone acetate. That's one which is the culprit. Medroxyprogesterone acetate in a high dose, something like 150 milligrams, way high than what we use in HRT. Normegestrol, which is one of the progestrogens used with, say, a combined pill like Zoili, which is available. So those were the three progestrogens out of all the literature review that seem to have some association with increased risk of meningioma. But that's with huge doses long term. Remember that these tumors are uncommon. And when I say increased risk, it will be very marginally increased risk. So it's not like you're going to get it very commonly. It's still quite uncommon tumor. Which were the safer ones? So far, it looks like the levonorgestrel IUS, like the Mirena or the others, the micronized progesterone and the dydrogesterone, so far have not been associated with an increased risk. Again, these are the three favorite ones for us when we look at the HRT. We say the Mirena coil, the dydrogesterone, the micronized progesterone are the best ones. So luckily for us, they haven't been yet associated with an increased risk of meningioma. And of course, as I said, if you stop the progestrogen or the progesterone, you expect the tumor to regress, stabilize, and then kind of keep monitoring the tumor further. What about the HRT? So menopausal HRT, inconclusive results, just like COC. Some studies like the Nurses' Health study, the Million Women study said modest increase in risk of meningioma with HRT, but several studies failed to show this association. There are lots of studies which say there is no increased risk. In fact, there is one small study which says estrogen only is not associated with any risk. And there was lots of meta-analysis trying to put these studies together, whether estrogen only increases the risk or the combined HRT increases risk. There is a lot of conflicting data on the HRT and meningioma. So we come to the final bit. What are the recommendations from the group? What do they recommend for clinical practice? They say that if you are taking some form of hormones and you're on a preparation of synthetic progesterone and you're diagnosed with meningioma, you must stop once you're diagnosed, because it could be it is associated with the development of that tumor. So it's best to stop and switch to something else and then monitor the tumor. If you're on a combined oral contraceptive, there is no consistent increased risk demonstrated. But again, if you're using a combination of estrogen with a progestogen, if you're diagnosed with tumor, stop that and try to find an alternative solution. This is really important, especially if you have risk factors like your own history in the past or family history of tumors or cranial radiation in the past. In those situations, you have to be even more careful to avoid these synthetic progestogens. The main ones are the cyproterone acetate and the medroxyprogesterone. Those are really to avoid if there is any history of CNS tumors in the past. Finally, with HRT, they say again it's conflicting data, modestly increased risk with some studies. If you're going to use HRT, use the micronized progesterone with estrogen or the dydrogesterone or the levonorgestrel coil. Those would be the ones to go for. But again, have that discussion. Is non-HRT option possible? Completely avoid HRT. But if the symptoms are bad, quality of life is an issue, one can offer HRT as a second line. But if you have to use it, then use the micronized progesterone or the safer progestogen. And then, of course, monitoring is important. If you've stopped somebody having hormones, or if they're taking hormones and you want to keep an eye on the meningioma, regular clinical examination, neurological, ophthalmological, regular MRIs, and they discuss how soon and how frequent these should happen. So it's a very useful paper in that regard. The one last comment they say is people with breast cancer risk or breast cancer often have associated meningioma risk. So the two tumors seem to have an associated risk pattern. So somebody with meningioma, make sure they're having their breast screening, and vice versa. If they've had breast cancer, be careful with the progestogens. Avoid the risk of meningioma. That's the last thing that comes through from the paper.
It is a really comprehensive one, isn't it? The other thing that I was going to say that struck me when I was going through it earlier today was the thought that estrogen might actually stop the tumour from growing as quickly.
Yes, again, not a lot of data to kind of support that observation. One would overall, this paper, as well as all the evidence we've had from contraception, from the HRT settings, is that it is the progestin which drive the tumor with the progesterone receptors. And although the tumor may have estrogen testosterone receptor, estrogen seems to be not a culprit so far from all the data we have. So it's the progestin type, and as long as you're avoiding the synthetic ones which are implicated, your options would be you can be on estrogen. We don't know whether it is going to make the tumor regress, but certainly may not make it grow. The progestogen is the key to avoid the synthetic ones, or just go for non-HRT if you can avoid hormones. Of course, that will always be an option if you don't have to take the hormones.
Yeah. Are there implications for people, because you mentioned they're the very high doses, are there implications then for people who might have endometriosis or other conditions that require treatment with quite high doses?
Yes, and so therefore, again, if you're using high-dose medroxyprogesterone acetate for any gynecological conditions, suppress endometriosis or suppress endometrium or contraception reasons, then of course discussion should happen. Again, important that in most of this situation, benefits of the treatment will still outweigh the risk, because these tumors are very, very uncommon. And so benefits of contraception, for example, for majority, or the therapy being given to suppress hormones will outweigh the risk. But it's important that discussion should happen, that high doses of certain progestogens do associate with increased risk of meningioma. And if the individual wishes to choose something alternative, they should have that choice offered.
And if people are interested as well in the study, it also talked about fertility treatment, which was interesting, and also the gender reaffirming
Correct.
the effect on that, which was is there anything specifically about those two things that
No, I think it talks a lot about CPA there. I excluded the fertility and the sort of other gender affirming therapies because it would be too much to cover in 10 minutes. But yes, if you're specifically interested in those sort of specific evidence related to those topics, they do cover all the papers there. It is the CPA, cyproterone acetate, being used in high doses in transgender people. And that's really the one that it talks about, that the counseling should happen if you're using it in high doses.
Okie dokie. Moving on then to the next one. Now, this one might make a few people unhappy because I guess it is confirming pretty much what has been said for quite some time, but a lot of people may not necessarily agree with this. So this is the role of testosterone therapy in postmenopausal women, a position statement from the North American Menopause Society. Take us away and tell us all about this one.
I think, Fiona, you will know far more on this one than me, because you've been writing your book and covering all of this in your book. But really, as you said, it kind of confirms what the clinical academics or people who are very sticking to evidence will say, this is what we should be doing. So testosterone has been a source of controversy over the last 5 or 10 years. We really started using testosterone about 10, 15 years ago as part of HRT. And there is more prescribing of testosterone happening now than before. A lot of women come and ask for testosterone. If you look at the paper, it's basically a panel of clinicians and researchers who were asked to sit down, look at all the literature that is existing on testosterone, its use in women post-menopause, and then come up with a consensus so that people can follow this in their clinics. What are the findings of the whole report? So I'll just go through each finding at a time, and then we can come back to the results and what they mean. So the first thing they say is that if you measure somebody's testosterone level, so endogenous testosterone level in the blood or the serum, that doesn't seem to correlate well with sexual function. So if you do somebody's bloods and you find a particular level of testosterone, that will not give you clear impression of their sexual function. It always doesn't mean that if you're low normal testosterone or unrecordable testosterone, you will always have sexual dysfunction. Vice versa, you could be having completely normal testosterone level and you could still be having sexual dysfunction or problems. And so the correlation hasn't been well established in the medical literature. And the reason they stress this is because there's a lot of testosterone testing happening now to come up with a diagnosis, which probably we don't know enough about. We shouldn't be doing that. The second one is they look at all the randomized controlled trials, and we look at randomized trials because they are gold standard intervention to know really is there an effect from giving an intervention like testosterone therapy. So what do RCTs say? They say there are a limited number of randomized trials looking at use of testosterone exogenously, whether you give oral testosterone or you give transdermal non-oral testosterone. It does seem to have positive effect on sexual desire, arousal, orgasmic response. So that's the good news. It does seem to do something. And whether it's a spontaneous natural menopause or whether it's surgical menopause, it seems to do a good job in both situations. So women who are going through problems with desire, arousal, or orgasmic response, they're menopausal. This is one intervention that does seem to be clinically relevant. And then they come down in the guidelines to say, what should be done before you offer testosterone in that situation? Who are the right women? So we'll come to that a little later. What about the controversial thing? Testosterone for well-being, for brain fog, for energy levels, for mood, for brain, for cognition. Unfortunately, science hasn't done good studies here. So when you develop guidelines, you have to say, I will stick to evidence. So far, there isn't any good data that testosterone is useful for these indications, whether it's bone mass, it's body mass, it's the vasomotor symptoms, flushes, sweats, the overall well-being symptoms. We need studies on this because we know there are some women who do report feeling better. For some, it may last for the first few months and then it disappears. For others, there are women who continue to report using testosterone and feeling better in many of these departments. But we don't know how much of that is down to testosterone, which is the subset of women who may be benefiting. Is this a true effect? How long can it last? There are so many questions which are unanswered. So when it comes to guidelines, safety first, you have to go by what is evidence-based. So the guidelines rightly recommend that at the moment, we don't have any data to recommend this for those indications. It talks about side effects. So we know some women can experience hirsutism, acne, oily skin. And so again, there is very little studied properly about these risk factors, who can get it, at what levels, and how long, and how reversible are these. We need better studies looking at the side effects, not just the benefits or the effects. Then it goes on to say, what about the long-term problems? So we know, for example, estrogen, progesterone, HRT, we say your risk of blood clotting is this with oral, not with transdermal. We can say your risk of breast cancer is 5 in 1,000 over 5 years with combined HRT. Do we have that data for testosterone? No, we don't. So we don't know what happens if you use for 5 years, 10 years, 15 years, 20 years, 25 years. Yes, we have some observational data, which is reassuring. We don't think there is a direct increase in risk so far, but it's limited evidence. It's few studies, few sort of long-term data to give us same reassurance that we have the right numbers as with estrogen, progesterone, HRT. And so we need more studies about risk with cardiovascular disease, risk with deep vein thrombosis, risk with breast cancer, any effect on endometrial tissue. There are very few data beyond 6 months. In fact, the guidelines say people have published very little even beyond 6 months of giving testosterone. Forget about the number of years. Then looking at the testing, again, blood tests are being used to document a level less than 0.5, saying you're testosterone deficient. That is not right because many of the common blood test assays don't pick up blood testosterone in women. So it says there is a major problem here because the current assays don't detect testosterone at the low levels which are normal for women. And it's really symptoms that should drive the treatment. No blood test should be used to diagnose deficiency and then offer testosterone. If there is symptom of sexual dysfunction, then you use the blood test simply to make sure it's not already high when you begin. So that's the baseline blood, is to only make sure it's not high. And then again, if you do a monitoring level 6 months or 1 year down, just to make sure you're not giving too much, it still should be within range. Other than 2, it's not for diagnosis or any other purpose. And finally, it recommends, if you do offer it for sexual indications, make sure that you've ruled out everything else, like a good clinical history. There shouldn't be relationship issues. They're not taking any medications like antidepressants or diuretics, which can depress libido. There shouldn't be vaginal atrophy, pain that's causing a reflex and a pelvic floor response. As long as you know this is related to the changes in hormones during the menopause, there's nothing else that's likely to be affecting it, that is the right patient for offering testosterone in that scenario. And it says about transdermal preparations being preferred over oral to bypass the liver, and it shouldn't be offered to women with breast cancer, endometrial cancer, or those with cardiovascular or liver problems, because we don't know much about these with the long-term use of testosterone. So again, in these indications, we see that there is increased use of testosterone in sort of women with breast cancer. Yes, individualization is important, and some women may wish to take it, but give the clear guidance and counsel. We don't have data. There may be in future some data which may emerge that it may impact your risk. Right now, if it is used, you will have to take this on the basis of benefits with unknown risk. That really is the key in counseling before you offer the treatment.
Okay. Now, there are going to be some people who are going to be very upset, as we know about this one. Is the counter argument that then is, basically you said, well, there isn't enough research. So, with that absence of evidence isn't evidence of absence, or whichever way around that goes. So therefore, we should give it a go with people anyway and see how they go on it.
Well, that is not academically correct. Clinically, yes, if a patient approaches you and says, I would like to have testosterone, and for reasons of either low libido, or I would like to explore if it has an impact on my mood, on my energy, on how I feel and my cognition, as a clinician, you will have to go through the guidelines and explain that there is no data. You'll have to explain that it may not help you. You'll have to explain the nuances as to what we do with the blood testing, whether there is any risk in the future that we don't know about. And then it's a decision between you and the patient. The patient can still have testosterone. It's a choice for every woman to decide whether she would like to take it or not, as long as you have made it clear that these are the uncertainties and that she may not benefit or may stand at unknown risks if they are published in future until we have the data. That's fine. Many women will make the decision, go ahead with testosterone, either continue if they see benefit or discontinue. So I think the important message here is don't give testosterone outside of libido. I give in my own practice, I counsel women and I will give them the testosterone when I feel there may be other benefits they may want to explore, not just the libido. But it comes with the counseling. As long as they are made aware of what is out there and don't go by something you've read or somebody has told you, when they have cherry-picked studies or they have only highlighted the benefits without telling you the uncertainties, then make that informed decision and you can have testosterone. So it's the kind of a shared decision. That is the key. What I worry about is, have your testosterone, it's less than 0.4, you're testosterone deficient, have it for next 10 years, it's going to make your life good. That sort of approach is what we are worried about. As long as it's counseled, it's evidence-based, and the patient makes a decision to try it, absolutely fine by me.
Okay. The other thing that you mentioned, heart disease, is this then people who've had heart attacks, or are we also extending that to people who've got, high blood pressure or other?
Everybody. So we don't have good quality testosterone data in people with established heart disease. There were a couple of observational studies which suggested the opposite, that having low testosterone may increase your heart disease risk. There were equally some papers in men who suggest that excess testosterone may be harmful for blood clotting or heart disease risk. So what we don't have is female-specific women's data with the current doses of testosterone we use on background of medical problems or complications, may it be hypertension, diabetes, stroke, heart disease, MI. We have to have that data. Hopefully in future it will come, but right now we have to explain we don't have it. And so therefore the lowest possible dose that helps you with your symptoms for the foreseeable annual review every year, and that's how you continue with the testosterone treatment.
And ideally make sure then that you've got controlled blood pressure and well controlled.
Absolutely. Work on your lifestyle, blood pressure, everything else to minimize any risk factors for any cardiovascular event.
Yeah. All right. Yeah, that was an interesting one. The other thing that's relatively, I'm going to throw a couple of things out of your left of field because you know I like to do that. There was a study that's just come out in the Aging and Disease Journal, which talks about the gero-protective approach that HRT could possibly offer. And it cites in there the 50% reduction in heart attacks or risk of having a heart attack, and also talks about decreased risk of dementia. How much credence can we put in that when really, especially when it comes to heart disease, that 50% was literally the difference between 1.1 and 1.8% or something, close to a 50% reduction, but really, really tiny numbers.
So you're absolutely right there. I read the paper. It's a narrative sort of review. It brings together all the arguments which support use of HRT early on in life during perimenopause and for sort of longevity, for preventing aging, and it's called gero-protection, which means you want to slow down aging or avoid it. There is no doubt that estrogen has lots of benefits, whether it's metabolism, whether it's heart, whether it's bones, whether it's the brain function. There is no doubt estrogen has benefits. But the paper is not a scientifically constructed piece of evidence-based sort of manuscript. It kind of draws and cherry picks research, which is in favor of estrogen that helps with various body systems. And we always factor in these sort of estrogen-related benefits when we do a benefit-risk analysis with HRT. But the paper talks a lot about, say, for example, I was trying to make notes. It calls deterioration of system with aging. Now, many people will be opposed to that. You can't call deterioration. Aging is part of physiology. Menopausal transition is part of physiology. To call it deterioration of organs would be probably a bit extreme. Again, the authors acknowledge about it's a hypothesis. It needs testing. That's exactly what it is. It's a hypothesis paper. We don't have robust evidence about benefits versus risk of HRT forever, say starting from perimenopause until way later, 3-4 decades later, about whether that is better than somebody else following very good lifestyle, non-hormonal treatments, and then looking at their life for 3 to 4 decades, head-to-head comparison. What about symptoms? It often says 90% of women will have symptoms like brain fogging. That may be, again, exaggeration, because often we haven't actually categorized menopause symptoms in a proper way, first of all, before jumping to offer treatments to women. It lists actions of estrogen at various microscopic receptor cell levels. It gives you lots of diagrams in there. That doesn't sometimes translate to clinical evidence. You can have fantastic animal studies, fantastic receptor studies, and very good mechanistic studies saying estrogen can transform certain things in tissues. But when you give estrogen to somebody clinically in blood and flesh, it doesn't turn out to be that way. So putting up lots of mechanistic study may mean nothing when it comes to clinical trials. And finally, it enlists a lot of cherry-picked studies and events there, like, for example, 50% reduction. So if 100 women take an intervention like estrogen, and out of those 100 women, only one stands to benefit by taking estrogen for 5 or 10 years, you could say it's 50%, but actually in real terms, it's very, very little evidence. So it's sort of those sort of figures and cherry-picked data that make me worry about the paper, the actual clinical relevance. It talks a lot about neuroprotective effects of progesterone. That's in very early stages. We don't really know how much neuroprotective effect on the long-term progesterone will bring in. It may perhaps, but we are in early studies of knowing that. And we cannot generalize to say it does that and it should be given to everyone to protect their brain in future. That's something we will probably discover over the next 10, 15 years. So again, I think you'll ask me the question, do we wait for that data? If you're a good clinician and a good scientist, you will wait for the data to appear rather than jumping to conclusion, because always with medicine, do no harm comes first. Can't hear you, Fiona.
Sorry, can you hear me now?
Yes.
Yep. The other thing, I don't know whether or not you actually had a chance to have a look at this one, was in climacteric today, severe obesity, menopausal symptoms and cognitive impact in postmenopausal Latin American women, which is suggesting that hormone therapy has a protective effect in those with severe vasomotor symptoms. And in some ways that actually fits with what Pauline Mackey's been saying for a while, isn't it? You know, if we're looking at the people who would actually really benefit in terms of dementia, we need to find the ones who have the uncontrolled high blood pressure, the uncontrolled cholesterol, and the uncontrolled vasomotor symptoms. Is that something that kind of does that make a sense to you?
I haven't unfortunately looked at the paper. I think it was out today perhaps, and you may have sent it to me. Sorry, I haven't looked at it. But I guess, again, the answer there is we haven't identified the subset of women who may benefit from estrogen for dementia. The only set we know are women with, say, POI, early menopause, women with the genes, the ApoE4 gene. We know they will stand to benefit. But anybody after 45 having natural menopause, which is the group of women that we can target estrogen as an intervention? Certainly not everybody. That would be overreach and kill. But which is the one that would benefit, what dose and what regime, and do we balance that against the small risks that do come with long-term HRT? That is something we'll have to study over the next decade or so. And hopefully MREF will contribute to that someday.
I sincerely hope so, because yes, that is the holy grail of what we really need to find, isn't it? Who can benefit most, where, when, and how, and why. Brilliant. All right. I think that we've sort of summed it all up, really.
Hopefully that was useful.
I think it was. I thought it was excellent. So there you go. Brilliant. Look, thank you very much. And I will, when I get around to it as soon as I possibly can, put the links in the YouTube as well, so people could actually have a look at those studies themselves. Excellent. Look, thank you very, very much, Vikram, and we shall speak to you soon.
Thank you. Thank you everyone for your time. Bye-bye.